Welcome, everybody. Thanks for joining us today. This is Ask the Expert for LAMA2 CMDs. Today's agenda includes meeting our experts, research questions followed by care questions, and then closing remarks. And we're going to be introducing all of our awesome speakers today. Judy, you want to start?
Yes, so my name is Judith Reinhard. I'm a researcher at the University of Basel in Switzerland, and I work with the animal models for LAMA2-MD since now more than 10 years. And with these animal models, we try to understand the disease mechanism and also develop some therapies, and I work on the development of gene therapy for LAMA2.
Valérie?
Hello, I'm Valérie Allamand. I'm a research director in the Center of Research for Myology in Paris, France. And I've been working on LAMA2 for quite some time now, starting with the genetics part and then moving on to the pathological mechanisms using animal models as well as cellular models derived from patients' biological material. And we're currently focusing on understanding the mechanisms in some cellular models, skin-derived cellular models that we are forcing to become muscle cells that are quite relevant to this disease.
Thank you. Anna?
Hi, good afternoon, good morning for everybody. I'm Anna Sarkozy. I'm a clinician working at the Dubowitz Neuromuscular Center in London in the United Kingdom. I see patients in clinic, but also involved in the diagnostic aspect, in particular genetic aspect, and have completed some natural history studies for this condition.
Kaitlin?
Hello, good morning. I'm Kaitlin Batley. I'm a pediatric neuromuscular neurologist, and I practice at UT Southwestern in Dallas, Texas. And we are also a site for the LAMA2 natural history study that's currently ongoing.
Right. Rotem?
Hi, everyone. Rotem Orbach. I'm a pediatric neurologist. I work at the Childhood Neuromuscular Neurogenetic Group at NIH. I'm a clinical researcher. My main focus is really about imaging biomarkers for congenital muscular dystrophies.
Rose?
Hello, my name's Rose Jenkins. I'm a registered dietitian with Cincinnati Children's Hospital in Cincinnati, Ohio, and I work as part of our interdisciplinary care team for the neuromuscular outpatient center.
Reghan?
Hello, I'm Reghan Foley. I'm a pediatric neurologist, neuromuscular specialist. I'm working with Dr. Rotem Orbach at the National Institutes of Health. Our group, our neuromuscular neurogenic disorders of childhood group, is focused on congenital muscle diseases and particularly focused on the congenital muscular dystrophies and a special focus on LAMA2. We also are a site for the Ready CMD LAMA2 natural history study.
Yes.
Hello, I'm Gustavo Dziewczapolski, Scientific Director at CureCMD.
And I'm Rachel Alvarez, Executive Director for CureCMD. All right, let's get into the research questions, Gus.
Perfect. So let's start with clarifying the nomenclature of LAMA2. The people was asking about the names partial versus full deficiency in the past, and now that this changed to LAMA2 RD1 or LAMA2 RD2.
So maybe I'll start, I think, and then Dr. Orbach can jump in anytime. So we had performed this international retrospective natural history study, which actually gathered data from the Congenital Muscle Disease International Registry. So the CMDIR, which CureCMD oversees, had gathered natural history, basically medical records for patients that were born between the years of 2001 and 2017. And looking at those 60 patients, we decided that it would be important for us to be kind of studying the different clinical phenotypes. And historically, people had used muscle biopsy and the amount of expression of myristin, whether it's present or absent, to kind of distinguish between different clinical groups. But actually, we decided for the purpose of understanding the natural history and for stratifying patients for future clinical trials, it'd be really important to understand the distinct clinical groups or phenotypes. So we decided for the purpose of the study, and in a way hoping that we could use this going forward, to try to define patients between those that sit, meaning those that can basically attain the ability to remain seated with or without support, meaning can be seated with pillows or seated by themselves, meaning ability to remain seated, not getting to sit, but ability to remain seated. And those patients we thought could be called LAMA2-related dystrophy 1 or LAMA2-RD1, and those that may attain the ability to walk, meaning the ability to take any unassisted steps by 3.5 years of age as being a different subgroup, or LAMA2-RD2. Now, this is kind of our proposal in our paper, which we just had published on this study back in I think it was 2024. So this is not yet fully used universally, but it's our attempt with our colleagues to stratify in a way which is clinically relevant, but also important for clinical trials. There are other nomenclatures still used. Some centers internationally will even say MDC1A, the original nomenclature, but we're trying to get a unified, harmonized clinical nomenclature going forward.
That's great, very clear. Rotem, do you have anything to add?
No, just to say that it really reflects the changes we see with clinical practice, which muscle biopsies that are no longer being performed. So we need to change definitions as we go, as we step into clinical trials and we understand better what is important. And same is with SMA. So we have some other examples with other diseases that seem been done for those.
Great, thank you. So let's jump to the next question that is also related to clinical research. That is, people was asking because they have seen reports about past and ongoing natural history studies. And so the question is if these studies are part of the same or are different studies. And if you can clarify where we currently stand with these studies.
Kaitlin, you want to start?
So I'm not as familiar with the other study, but I know for Ready CMD, LAMA2 natural history study that's led by Dr. Ann Connolly, we are still enrolling. And so I know almost all of the sites, I think, are up and running. And Reghan, I think you mentioned 12 of the 14. I think that's the most updated. Perfect. And so I think, thankfully, we cover a wide geography throughout the United States. And so my hope is that, there's a kind of somewhat close site for most patients and their families to be involved. This is enrolling young kids, as the main goal of this particular study is to assess clinical trial readiness for the very small ones, so less than 5 years old. And so we can definitely, if the link's not available, maybe we can put it in the chat for the clinicaltrials.gov information, and that has all of the sites listed on it. And if anyone has any more specific questions about like what the trial entails or, day to day, what this looks like, what kind of time investment would be made by your family, that kind of thing, I'm happy to talk about that too, if that's relevant.
And I could add that I think the question was also kind of wondering about other centers internationally. So we had attempted, going as far back as 2020, to have one international prospective natural history study. The complicating factor there was logistics, different legal requirements, different countries, as well as funding. So what's happened is not a negative thing because we have now multiple validation cohorts, but we really have currently, as Dr. Batley mentioned, this Ready CMD LAMA2 across 14 sites, ultimately now 12 are active in the US. There's also a study going on in Brazil, study in France, Netherlands, Spain, Switzerland, and Italy. So multiple cohorts. We are predominantly looking at the same exact outcome measures. Some centers have extra outcome measures. So all this data is going to be essential, important lead-in data for future clinical trials.
So these are all separate studies, but you have communication between the studies, and the learnings will all be combined, I suppose, right?
We do meet every month. We have the International LAMA2 Consortium, so most of the folks on our most of the panelists are part of that, and we have so it's scientists, clinicians, and even some folks from industry that meet monthly for updating on research, and also different sites internationally that are doing natural history studies have that as a forum. So we really all communicate, very unified, collaborative effort internationally in sharing all that data for the purpose of improving clinical trial readiness.
Perfect, great. Anybody else has anything to add?
I just wanted just to add very quickly, because there is a comment also about past studies. So
Yeah.
there have been some studies completed already, and some that were longitudinal studies, but also some centers, including ours, we looked at patients that have been seen over the years. So that's what we call retrospective clinical studies. And these are also very important, maybe not as detailed, as not sometimes the data is not as accurate as prospective study like the ones that the colleagues have described. So it's both studies are important, but the data you collect is clearly different. I just wanted also to highlight that it's very important in the meantime for those families who are not part in a natural history study to aim to get a clear genetic diagnosis and possibly make sure that they follow standards of care so that perhaps in future their data can also be collected.
Reghan, did you want to mention the original LAMA2 natural history study?
The original, well, there's actually multiple that kind of, and maybe I make sure I begin, Rachel. So Dr. Sarkozy and her colleagues had a cohort of 46 patients in the UK looked at. China had a cohort of 130 patients retrospective. Netherlands had 27, Qatar is 21. So lots of robust retrospective data. The original one, Rachel, would that be retrospective or?
The COM study.
Oh my goodness, yes. So we had done it at the NIH. It was over the course of 4 years, CMD-COM, Common Outcome Measures Study, where we brought in patients with LAMA2-related dystrophy, as well as patients with collagen 6-way dystrophy, and looked at outcome measures over the course of those 4 years. And that was really important for defining the number of patients we'll need for future clinical trials, as well as change in motor function and pulmonary function. We did not look at children under the age of 5. And so the Ready CMD LAMA2 study that Dr. Batley mentioned is precisely looking at those first 5 years of life, where we really need to know that natural history data in more detail.
Talking about clinical trials, that was mentioned many times already. People is wondering where are we at for clinical trials for LAMA2, and if you can comment on which research studies are moving forward toward clinical trials.
Anna, you want to
Probably
start?
the first response is that we are not having any current clinical trial going on, but there are some studies in pipeline, right? Go ahead, any of you guys. Can you comment on which research studies are moving forward?
Yeah, so I can try to summarize what research is ongoing in the field, and I think the potential therapies developed are either gene therapies or also therapies which more target the downstream mechanism of the disease. And there are 2 gene therapies in development. One is by Modalis Therapeutics, now a pharma company, that tries to move this forward. Another gene therapy is developed by us. So this is actually academic research, which is now under the umbrella of a startup company. And on the other hand, there is a lot of research also on potential downstream mechanism of the disease and also the development of novel cellular models to study the disease, and also early research also on potential cell therapies.
Great, very nice summary. Anybody else has something to mention? Valérie?
Yes, if I may. Yeah, I just wanted to add also for what we are doing as early research in cell models, that is therapy targeting specific mutations, nonsense mutations that lead to premature termination codons using some tools called tRNAs. And so it's one type of gene therapy, but not bringing the defective gene, but bringing a tool to correct a mutation.
Perfect, great. And last part of that question was people was wondering if the efforts are communicated across international groups or if they are siloed by country.
Yeah, so I think this already Reghan mentioned that scientists, also clinicians and researchers are very regularly meeting and actually exchanging their knowledge, also their scientific approaches and their results, and which means we are very much communicating with each other. And so if there is progress, this is actively shared within the community.
Yeah, and I'd like to add that the communication is also greatly facilitated by patients' association. in the US, queer CMD, of course, but also in Europe and other countries. So that's a very, very important contribution from the Patients Association.
Yes, thank you for mentioning that.
Can we pause for 1 second and introduce our other two guests?
Yes.
Clara, do you want to introduce yourself?
Thank you, Rachel. Hi, I'm Clara. I'm a child neurologist from Brazil. I work in University of São Paulo, and I'm interested in neuromuscular disorders, especially in LAMA2.
Hank?
I'm Hank Meyer. I'm a pulmonologist from Children's Hospital of Philadelphia and have had a longstanding interest in neuromuscular disease and defining the pulmonary standards of care and some pulmonary outcomes.
Thank you. Okay, guys.
Okay, so where are we? There was a question about if there is use of CRISPR, if it's research on the use of CRISPR in LAMA2.
Maybe Judith can comment on the technology that Modalis is using. It's a bit complicated, yeah.
Yeah, so Modalis is using therapy or an approach which was originally developed in Toronto. And this is an approach which does not use the classical CRISPR to fix or correct a certain mutation, but it's an approach that uses a modified version of CRISPR to upregulate another gene. In this case, this is LAMA1. And then the expression or upregulation of this gene should correct for LAMA2 deficiency.
Great. And I can add that CRISPR has been looked for LAMA2, especially because LAMA2 is a very large gene. So the classical gene therapy will not work because you cannot pack that big of a gene in AAV vector. So people is looking at the use of CRISPR to do gene editing inside. So yeah, CRISPR, but CRISPR is behind in the pipeline to the clinical trials. There are many safety issues that are still not resolved. But yeah, is used in LAMA2. I was going to ask, you mentioned, Judith, about the LAMA1 upregulation. And so any of you can mention about the protein replacement that in the past a couple of companies have tried to?
Yeah, I can also add to this. So in the research community, it's very clear, and there's a lot of data that we could replace LAMA2 with LAMA1. And so one approach is to try to actually upregulate or to express this gene in the patients. And the other approach was to try if LAMA1 as a protein replacement therapies. And this is also academically developed originally and was then tried to move forward in several companies.
Okay, thank you. One question is about stem cell therapies, if they have a real potential in LAMA2.
So I think the general challenge for cell therapies is actually to bring in sufficient cells that can improve the muscle in a sufficient amount to actually lead to meaningful improvements of muscle function. And this was so far not achieved, but also there's a lot of research ongoing also for other diseases. And eventually there is a breakthrough in the future, and then cell therapies also become more applicable eventually also for LAMA2. But at the moment, this is not something that has shown very much efficiency in these diseases.
If I may add, I think also one of the challenges for cell therapy is identifying the right cells to bring into the muscle to express whether it's LAMA2 or any other protein. So I think that's also why, and then their survival once they're in the tissue. So that's why it's behind, I think. and hasn't been developed so much for LAMA2.
Yeah. Okay. Yeah, and I can also add that this is something that has been going on for many years now, since researchers were able to manipulate cells and grow it in the labs and modify them. And so it's a brilliant idea. It's a very nice idea, but the technicalities and safety issues in injecting those cells into patients is still a big barrier. But there are many labs in the world working with stem cells because they have really potential to be to be effective, but we are very far away of the real solution or real treatment with them yet. So just to clarify, when we talk about potential or upcoming clinical trials, we mentioned children. So are the clinical trials planned only for children, or there are some for more young or adult patients?
Maybe I can start, and anyone could take
Yeah.
it further. But I think what happens is any therapy in development then has to go in an application to a regulatory agency like the FDA and the EMA. And sometimes that feedback is that they prefer to start in an older age group. For certain therapies that we were talking about, the gene therapies, we're probably going to aim initially towards the younger patients, but that does not mean it could not be expanded to the older patients. We had done in the past, we had done a trial, phase 1 safety and pharmacokinetics of a megapill. That was for LAMA2 patients, ages 5 through 16, and collagen 6 patients, 5 through 16. That data showed that oral compound, which is an anti-cell death or anti-apoptotic medication, is safe and has a nice profile in the blood. It's not taken forward yet because of some need for further animal model data for the collagen 6 patients, but also some need for further defined biomarker signatures. But that may be used in the future as an adjunctive therapy and definitely applicable for adults. So that's yet to be determined, the ultimate age range for patients in clinical trials and ultimately the approval of these therapies.
Thank you.
And I think also, if I can add, that independent of age, we still need to understand what would be our goals, what would be the endpoints that prove that the drugs are actually working. So I think that we're still not quite clear, even in children and especially in adults, what would be expected from the patients if they are improving with the drug, and how we could prove to the agencies that that drug is actually working.
I think this well connects with the next question about the biomarkers, which would be also outcome measures. So perhaps this might be very different in adult populations. We might need to have natural history studies in older patient groups to then develop, assess the efficacy of these, right?
And to speak on behalf of Dr. Nicole Vormans, I think she would say she is looking at so her focus
Exactly.
is adult patients with congenital onset diseases. And so her team has, in Netherlands, has a natural history study that includes adults with LAMA2-related dystrophies and data to have.
Yeah, so when we talk at the beginning about natural history studies, and you, Reghan, mentioned all these studies going on, we are covering with these natural history studies the whole range from newborns to the very adult population, to have those tools to be clinical trial ready for when any potential therapy can be moved forward to patients. So Anna mentioned already about the next question and about biomarkers. So can you give an update about the search for suitable biomarkers for LAMA2?
Sure. I'll start, Gustavo, and then I'll pass the baton also to others, including Rotem, who's looking at imaging biomarkers. So I've been looking at basically biomarkers in the blood. So an easy way to test, if we can, would be to get a blood sample during the course of a clinical trial instead of having to do repeated muscle biopsies. And so I've done a pilot study, and that data is being finalized now, some exciting data. So looked at a cohort of patients with LAMA2-related dystrophy, looking at the serum for certain markers, including microRNA, which are these small non-coding RNAs that are stable in the blood at room temperature and easily can be tested. And what we are looking at is a disease-specific signature, meaning findings in the blood, both microRNA, also proteins, proteomics. related to LAMA2A dystrophy and also disease stage specific, meaning you basically a different profile at a different age because it changes over time. And that data is very promising data, which we also like to be able to use in the course of future clinical trials. And that work has been supported by Cure CMD, LAMA2 France, LAMA2 Europe, Vorsara, Impulsat. So a lot of LAMA2 patient and family organizations have helped to support that work. And I was able to get control samples for that control cohort from colleagues at the Infant Center at University College Cork, Ireland. So that's coming out, that data shortly, but there's also very promising other outcome measures and biomarkers, including imaging biomarkers that Dr. Orbach can mention.
Yes, so just to give a little also additional context from a regulatory perspective, all the performance-based outcome measures are great, but if we can supplement them with a surrogate biomarker that is strong enough to reflect on treatment response or disease progression, that would really make the claim to the regulatory authorities much stronger when we come to ask for approval. And as Dr. Foley mentioned, she looked at some blood biomarkers, but we can also look at other stuff like electrophysiology and imaging. Specifically, I've been focused on a new, it's still investigational research technology, multispectral optoacoustic tomography, where you can use light to know how much collagen and how much fat you have in the tissue. So even before maybe the patient shows you by performance that is being affected by the disease, you can look at other more kind of deep tissue changes that you don't need to have a biopsy for them. So all of that, if proved effective, could help us when we come to the next stage, to clinical trials, and make the claim about what the treatment is doing for our patients.
Great, thank you. And there were some people asking if international patients would be accepted to participate in clinical trials. So maybe we can try to educate how you recruit for clinical trial and the international barriers.
Should I start? And maybe Dr. Sarkozy wants to mention too. So what happens ultimately is when we start these studies, whether it be natural history or interventional studies, a few sites are the initial sites for those studies. And then ultimately we intend always to have a network of other sites internationally. We often say, at least for our site, the National Institutes of Health, that if you're an international patient and you want to come be part of a study, wait until there's a therapeutic study, a medication. The natural history studies, we wouldn't recommend traveling. The burden of travel is so much and the risk of, of a long haul flight. But when there are therapies that are available, they will be available at multiple sites internationally. And if you do want to participate, and you're not in the country where the clinical trial is being run, you can have a conversation with the different sites about what's feasible.
Yeah, I mean, I don't know how many of the attendees are from countries outside the US, but in Europe, we often hear families who, for example, think about traveling quite far away for trials. And it's always something that has to be put in the context of family situation, possibility, and different aspects of how this is feasible for a family and for the patient themselves. So I think it was also important, as Reghan mentioned before, if it's a therapeutic trial, also please remember that many of these compounds are being investigated, so there is no proof that these therapies will be of clear benefit. So these are clinical research studies. So it's important to think carefully about these difficult decisions, and very often some also to other countries in Europe and around the world. And hopefully once the therapies are shown to work, will be, more widely available. So it's a complex discussion, I think, but we often are. And also I think it's important that you speak with your clinician if you are interested in a trial, and ask advice to the person who knows you best and can maybe contact that specific center and advise.
Yeah, the ideal, of course, is to bring the clinical trial to all the countries, all the cities, but it's impossible, but that's the try. Yeah. So, and usually if a site or a country cannot reach to the number of patients they need for the clinical trial, so then they can be probably a search outside. the country or that city, right?
Yes, and for sure. But I think in particular internationally, the other aspect to consider is if there would be, so if you travel far away for your clinical trial, would your standard of care be provided in that country where you're traveling? So I think that's also maybe another aspect to maybe consider. But we hope that more and more trials will be more, available in multiple sites in multiple countries.
Yeah, and one clarification is that a clinical trial is an experimental use of a drug, it's not the treatment. So, of course, the idea is that if the treatment then is approved, it will be available around the world.
Exactly.
Right? So, and related to that, there was a question of how do you get involved and how do you learn about clinical trials? And I can respond from QCMB that one important tool is if you register in our registry called the CMBIR, and I think I will put the link already in the chat. And from there, you will get notifications about any clinical trial or clinical study that is going on worldwide, and specifically in your case for LAMA2. And I don't know if anybody else has any. How do you get involved? I think we already covered. Yeah.
Yeah, I think a registry, like you mentioned, and also in Europe there are maybe in other countries there might be other registries of patients with muscle condition and so on that could possibly link the families up with ongoing clinical trials. And for example, in larger clinical centers there might be internal data sets of patients who just to log interest of families about clinical research, so that if there is a research ongoing in that country or in that center, the families could then be put in touch with the specific clinical studies.
Great. One last question about research. There was a couple of families asking about research into the use of creatine for keeping or growing muscle.
So I can say from the research side that also in the animal models and so on, there was no research done on the specific use of creatine and LAMA2. But I think I pass over to the clinicians if they recommend to use any supplements for patients.
Yeah, so I think we have a question in the clinical side about supplements in general, but I think in particular, I didn't know about the use of creatine in LAMA2, so I did some search in bibliography, and I found a couple studies in Duchenne or other muscular dystrophies, but as far as I understood, there was not benefit of using it. I don't know if anybody else has a comment.
I find response very individual to creatine, and it's generally speaking a benign supplement. So I'm not objecting when my patient wants to try that, but at the same time, I don't think they're, like Judith say, like a specific rationale here for LAMA2 and creatine supplementation. As you know, many people take it, even like healthy people that wants to build and improve the endurance of their muscles.
Can I just maybe jump in on this? I think it's important in general with others in supplements, just in thinking about future clinical trials, that it's very important, however, that if you take supplements to always disclose the supplements that you take to your clinician, because some of these compounds may be perhaps compounds that may not be allowed if you are in a clinical trial. So just to be sure that if you decide to take any supplements, that you discuss them with your clinician, make them aware, and just to log the information in your records.
Okay, and maybe we can finish the research part with a question of how can the community contribute to research?
I think the community already has. I know that Dr. Sarkozy was just at the LAMA2 International meeting in Istanbul. I had spoken yesterday with a company in Modalis who were developing a therapy, and their comment was they were so impressed by the patient community, blown away, having been to multiple different community days and whatnot. But the communities really showed up in many ways, not just at conferences, but in sharing their data, their medical records, giving blood samples, doing outcome measure studies. So I think the community should feel proud about that.
And registering in the registries, especially in the CMDIR.
Yeah, can't advocate more for that. And just for the community to know, whenever someone like an investigator comes to the authorities to submit a grant funding to run something, they need to show the patient input in that grant application. It's super important for the community to participate, to support. That's the way to get the money going the right way, to the right direction.
Yeah, that can also add kind of, as a researcher, which usually does not see patient, it's actually also great motivation for us to actually see patients, to be in contact with them also at QCND meetings, for example. This is a great motivation to keep research ongoing also.
Very good, yeah, thank you.
And
Yeah.
I think it also helps us in academic researchers also to know what's important for the patients in terms of clinical output or clinical difficulties, and that can, in a way, orientate a little bit also the academic research. And that's very important because there might be things that we don't think about because we are using cellular models. But then if some things can be replicated in a dish, cell culture dish, or in an animal, and that's very important also to somehow orientate a little bit the focus of the research, because what's important to the patients is what we need to improve with clinical trials.
Yeah, and I can add that it has been, and it's going to be an ongoing basis, meetings, research meetings, workshops, where usually from the CMDIR we reach out to families that are registered to ask specific questions, and then we bring those that data to the meeting to inform the clinicians and researchers about what patient voice is at. Anything else, or we move to the care questions? Rachel, time-wise, I think we.
Yeah, we need to move on.
Okay,
All right.
thank you.
So, thank you everybody for those research responses. Moving into care now. My first question is about kind of the things that we need to be informing primary care providers, like pediatricians, or for adults, primary care providers during routine examinations or routine care, and then also for acute care. So if you're in the emergency department or the urgent care, what are the key things about LAMA2 that you really need to make sure that your current provider is aware of?
I can jump in here and start because I feel like I have this conversation a lot with my family. And so, I think one of the most important things is to help providers who might not be as familiar with neuromuscular disorders to know where to access or how to access the information that they need. Obviously, as a general practitioner, they have to know a little bit about everything. And so, really need to be able to depend on us as specialists and then the resources that we're able to provide to then give more specialized care to an individual with neuromuscular disorders. So I typically print out the Cure CMD guidelines for especially for respiratory care management. And I highlight the sections that I think are important for emergency physicians if they're seeing one of my patients in the ER, for instance, for a respiratory issue. And then I tell my families, I'm like, this is something important that you can bring to your doctors that can tell them what they need to know. And so I think, that document, as well as how to contact us. We have an on-call physician, 24/7 at our university. And so they can always reach out to us if they need additional guidance. And so I think that's one of the most important things, is being able to connect to the people who can help them answer the questions they need, because it's a lot of information, and oftentimes it can be a lot for families to convey all of the details, because especially if you're in an emergency situation, there's a lot of emotions and high stress. So just to be able to reach out to us, I think is important.
Clara, what do you think?
I completely agree, actually. I think that what people need to know is the basics. And I think that understanding that not all doctor from the ER is going to be aware of every specific thing that a patient with LAMA2 has to be attended. But I think that here we have to combine both the fact that we as the primary physicians give this letter to the patient so they understand, especially about the pulmonary care, what is the most important things that they should know. But I think that it's really important to have this kind of conversations with the families and the patients themselves, so they too can be their own experts. I think that this allows them to be more safe, and in a way, they also can help the physicians in the ER and go through some specific aspects that we should be aware. It's impossible for all the physicians to know everything about rare diseases. So it's important for us to spread the word, but also for the patients and families to be a little bit owner of their own history, especially on those specific moments of need.
Great. Hank, pulmonary wise, what do you?
Yeah, I echo a lot of what was just said. And I think you need to assume that if you're not going to a large university-based emergency room, that you're going to an emergency room with people that don't understand the general concepts of respiratory care and neuromuscular disease. And certainly providing resources like the care document that Cure CMD has, and other similar documents is helpful. But I think going with the care plan that the respiratory team that supports your child or you has put together, and going ready to advocate for what needs to be done, I think is absolutely critical.
Rose, did you want? Oh, Reghan, go ahead. Sorry, go ahead.
Sorry, I'll be brief, and then Rose definitely needs to jump in. I just want to mention one thing for parents to be aware of that may occur, not to be surprised by, and to also inform the local ER about, is in young children with LAMA2A dystrophy, probably most related to a young liver and small muscle size. There's a tendency for low blood glucose. We call that hypoglycemia. It's part of the condition. Does not require a long hospitalization and endocrine consult to look for some sort of pancreatic tumor. No, it's part of the condition. And actually, we've seen the children grow out of it, but the first few years are tough. And so if the child's vomiting and not eating, there's a fever going on, an illness, or you had a long haul flight, you missed a meal, the child with LAMA2A dystrophy is going to be very, very much inclined to have low glucose. You tell your local team that they can provide you with glucometer. So if your child's vomiting at 4 a.m. and looks gray, you can check the glucose, get a sugary drink, and address it in real time. So again, that awareness is key for decreasing stress, but also able to address the situation in real time.
Rose, did you want to add anything?
Yeah, I think what Dr. Foley said, and then to kind of echo that, with our patients having smaller muscle tone and less ability to have reserve stores during these periods of illness, just stay in communication with their neuromuscular care team along with their primary care, and letting them know, if there's a dietitian on staff, this is what they've been eating the past couple of days. I've really noticed, a decrease, and just keeping an eye on that and in communication with the team.
Anybody else have anything for primary or emergency doctors before we move on? Okay. In terms of diet, medication, and supplement recommendations, Rose, I'll start with you, but I think let's talk a little bit about what we recommend in general for those living with LAMA2.
Yeah, so, with LAMA2, I feel like specifically with diet, we often see more patients with underweight or poor growth. So, taking into account the whole picture of the patient, knowing that growth charts may not necessarily be, the best only indicator of how the patient's growing and what their nutrition status looks like. But if possible, having a dietitian available to see the patient every 6 months to monitor weight gain, daily weight gain and linear growth between visits, looking at diet recalls with the dietitian who can, check to make sure that protein, carbohydrate, fat goals are being met along with micronutrient goals. And then another part of our assessment is really looking at calcium and vitamin D goals. So in our clinic, dietitians will go through a daily recall for calcium, just because blood levels of calcium aren't a great indicator of how much calcium we're getting in our diet. And calcium's a really important mineral along with vitamin D for supporting overall bone health and preventing, bone loss and fracture risk. And then again, vitamin D really monitoring that serum level, so getting labs. In our clinic, we do every 6 months, as that's another important vitamin that works with calcium to ensure that calcium is getting to our bones and keeping our bones healthy and strong.
Anybody else have anything to add? Great, that was easy. Is there a point at which physical or occupational therapy is no longer beneficial? This is kind of an interesting question.
I don't think so. I think that goals will change depending on, where a patient is at and their current muscle function. But I think that there is always a benefit from physical and occupational therapy. And, whether that looks like stretching to improve joint range of motion and, the kind of optimization of splinting with orthotics, hand splints, AFOs. Or whether that looks like, increasing physical activity through using the standing frame. I think there's always something that they can add and, use to optimize quality of life as well.
Would you say the same for adults?
I would.
Okay. Anybody else?
Hank has a question.
Yeah, I would strongly advocate for continuing as long as possible, even if functional preservation isn't there, because of improving or maintaining flexibility of and function of muscles and joints, preventing contractures is exceptionally important. And I wanted to throw in speech therapy also to maintain swallowing function, even if you get to the point where you aren't able, or your child's not able to maintain a safe nutritive swallow, and feedings have to be administered through a gastrostomy tube. It's still critically important to maintain swallowing function to be able to handle upper airway secretions during acute illnesses, and that can really be a major determining factor between a cold versus a cold that leads into a lower respiratory tract illness or a pneumonia.
Asking Hank you to lead into the cough assist, maybe.
Yeah, that's one of my notes.
Sure. Yeah. So there's a device called the cough assist, or generically mechanical inexsufflator, and it's a device that has a little turbine inside that either blows air into a patient when they're trying to breathe in, or helps to pull it out when they're trying to breathe out. And it can loosely replicate the cough maneuver that one does. And when you lose the ability to take a deep breath and cough effectively, you're at risk of having prolonged and more severe lower respiratory tract illnesses. And it's really the only way to clear the lungs of secretions, period. There's nothing else other than a cough assist device. And there are devices that people will add on, such as vest therapy to vibrate the chest, and other devices to help inflate the lungs. But it's really the only way to facilitate getting secretions out. And the optimal time of doing that is ideally before you have that first big illness, should you be so unfortunate. The challenge is figuring out what time that is. And there are some outcome measures, such as peak cough flow, that can be used to loosely determine when that time at what time you should start using an inexsufflator or cough assist. But it can be very, very important in maintaining respiratory health when you are unable to adequately clear secretions on your own.
Can you talk briefly a little bit about those early years when kids are not quite tuned in to how to use the cough assist? Like, what are the techniques that you're using to get them keyed in?
Persistence and art. What I mean by that is when you do a treatment, you put the mask over the mouth and nose, or if it's somebody that's able to hold a mouthpiece on their mouth, they can do it that way. And you then will say, okay, breathe in, and then you apply positive pressure, and then push the air out and you apply negative pressure. That's the ideal situation. When you have a child that's uncooperative because of their developmental status, meaning a young infant or toddler, or somebody that is unable to cooperate because of a sort of a central nervous system challenge, then it becomes a challenge in trying to predict when the patient's breathing in, applying the air, and then trying to predict when the patient's breathing out. And it is doable. It just takes a lot more practice and teaching from an experienced respiratory provider.
Great, thank you. And on the topic of pulmonary care, when are we starting pulmonary function testing, sleep studies? How often? What are the indicators to begin breathing support? And what are the benefits of breathing support?
Typically, patients who are cooperative are able to produce reliable pulmonary function between 4 and 5 years of age. And so at least in our practice, routinely start doing testing in patients when they become 5 years of age. And we have accurate normative data to go from 3 all the way up until the late 80s, early 90s. And so if you do have a cooperative patient, you can certainly attempt doing pulmonary function testing and then get useful data, normalized data starting at 3 years of age. In terms of a sleep study, there's no strict guideline as to when to start using it. The simple answer is when you have a concern about sleep quality and need to, from that standpoint, assess for hypoventilation or respiratory failure. There have been some general recommendations to get an annual sleep study just as a screening tool. I typically don't like to do screening tests. I like to do tests that for which I have concerns about what you're testing for. The challenge, however, is having a provider that's in a position to be able to ask proper screening questions and make a judgment as to when to do a sleep study. Borrowing from other conditions where we have much better natural history data, such as Duchenne muscular dystrophy, the general guideline is once the vital capacity, which is the volume of air you can move through your lungs when you take a full deep breath and breathe out completely. When that number drops below 50% of predicted, at least in Duchenne muscular dystrophy, the recommendation is to strongly consider the possibility of nighttime respiratory insufficiency and going ahead and getting a sleep study. So that's the best not validated in LAMA2 recommendation I can make.
I'm going to add just one little thing, which our retrospective study, Dr. Orbach was involved in the 60 patients internationally, LAMA2-related dystrophy. What we've seen is in those kids that are less than 5 years of age, who cannot yet do pulmonary function testing, 40% of them internationally were already on non-invasive ventilation before age 5 years, meaning if we look, we find issues. And so in those children whose maximal motor milestone is getting to a sitting position, most of those will need to be on non-invasive ventilation, and most by 2 years of age, and 96% by 5 years of age. So I think we should be looking, because we have the ability now to look, and we hadn't done so historically before, the year 2000 or so.
Great. And what are the benefits for using breathing support?
Let me just make one final comment about sleep study. The one thing that makes me uncomfortable about having a blanket recommendation to get a sleep study at a certain frequency without symptoms is excess. We have a sleep lab that has roughly 20 beds, which sounds like a lot, but the typical wait time getting to the end of the line is about 9 months. So we can often arrange for a more facilitated sleep study if truly needed. But I just want to caution about making sort of a very broad recommendation of getting sleep studies at a certain frequency. Very much in favor of them, but I think we need to be a little cautious because it's, it's difficult to get. There is an alternative, and that is doing capnography studies, which are now able to be done at home with something called a transcutaneous carbon dioxide monitor, or TCOM. At least in our practice, doing that at home, and our adult colleagues at the University of Pennsylvania are doing this routinely to both monitor their patients and then evaluate. To answer the question, a respiratory support device or ventilator is helpful to take over improve breathing at night when you go into deep sleep and your muscles don't move quite as broadly. What it does effectively is through a nasal interface over the nose or into the nose, it applies positive pressure synchronized with breathing in and then drops to a lower pressure during breathing out. And that can help improve minute ventilation, or the volume of air that goes through the lungs in a minute, and decrease retained carbon dioxide, which is how we diagnose respiratory insufficiency, and then also help to prevent low oxygen, which if it's persistent and significant, can cause right heart strain. So when I start non-invasive ventilation on patients, irrespective of condition, because of high CO2 and low oxygen, the morning afterwards, they feel absolutely tremendous. And so it's not just a matter of supporting ventilation, but it also improves sleep. It can improve daytime function, and just can make you feel a lot better.
Excellent. Okay. So we're running low on time, but I want to get through two pretty critical questions. I'd like to discuss the frequency of cardiac symptoms that we expect to see in LAMA2. What are the recommendations for routine monitoring? We unfortunately don't have a cardiologist today, but Clara, do you want to mention briefly?
Yeah. So from what we've seen here in Brazil in our patients, it's really rare for the patient to have any cardiac symptom. But from the second decade on in life, they might have some rhythm problems. So it's good to have a Holter to at least see if the patient has some kind of blockage or something like that needs specific treatment. But it's usually not common. So in that scenario, I think that from the age 10 and older, it's good to have at least one exam over every 2 years. And prior to that, we can do at least once. And if the patient has a really severe pulmonary function, then I think because the heart can be affected, then we should also check the heart.
And we're talking about echocardiogram, right?
Yeah.
Okay.
Maybe can I just quickly add on this? I fully agree with this, but also just to add that often children have to have surgeries earlier than before their teenage years. So perhaps it's even more important to look into cardiac aspect before surgery. And also we perhaps don't know yet, because these aspects were less investigated so far, perhaps we just don't know yet the real incidence. And sometimes, as you said, symptoms may not be there. So, perhaps we need to have a bit more research to fully understand the prevalence of cardiac involvement. So if possible, routine cardiac investigation would be helpful, perhaps in, all ages, but definitely more if you're a little bit older.
Okay. And can we talk briefly about brain abnormalities that we expect to see in LAMA2 and the likelihood for seizures? Anna, why don't you take that one to start?
Yeah, so I mean, brain abnormalities, we know that there has been described in quite a number of patients. The prevalence have been different in different studies, but it's definitely something that is seen in many patients, and then can be small change that are only present on the brain MRI, but there might be also more obvious abnormalities. And in some patients, they might evolve in seizures. Again, numbers or frequencies of the involvement is relatively, it's variable between studies, but it's definitely something that is seen in quite a number of patients with LAMA2, and treatment are possible. So it's important that these, seizures are investigated and treated. And this is something where, there are medications available for children. So that is important aspect to monitor. But brain MRI changes are seen almost in all the patients, but they might not equal to presence of seizures. So it's important to be aware of that brain changes do not equal to onset of seizures.
Are we still expecting that there was a statistic that's been longstanding in the community that about 30% experience seizures? Do we feel like that's still probably right?
Yes, but again, in our cohort, for example, was a bit lower than that. So as I said, probably it's somewhere around that number, but some studies had slightly lower, slightly higher, but yeah.
And we're seeing that sometimes they grow out of them, correct?
I think yes, but also probably treatment intervention and so on. Yeah.
Okay. Anybody else have anything on seizures?
I think it's really important also to mention to the parents what seizures look like in the LAMA2 patients, because it's usually not the common seizures that people expect, the tonic-clonic seizures. So they might be just an experience of nausea or the perception of different lights and visions, because of the area of the brain that's affected can be a little bit different. So it's important to make the parents and the patients be aware what would we look like, so they can mention to the physician they're experiencing something that's different.
Okay. Anybody else? All right. Well, I'm going to end it there. We're going to have some questions we didn't get to, but we were going to, the plan is to create a document for the community for the questions that we didn't get to, and then we'll probably be reaching out to some of you for help with those. So thank you so much, everybody, for joining today. Really appreciate your time. We're grateful for your expertise and your collaboration, and we look forward to seeing you again soon. Take care, everybody.
Thank you all.
Thank you.